Hello, my name is David Ansara. Welcome to our exclusive CRA client briefing. We're delighted to be joined today by a guest speaker who I'll introduce in a moment, but we're just waiting for participants to enter the call. I see them streaming in at the moment, so if you could just bear with us for half a minute or so whilst we allow for attendees to join. All right. Well, thank you very much. As I said in the introduction, my name is David Ansara. This is an exclusive CRA client briefing, and it is focused today on the risks associated with the National Health Insurance Policy proposal. There is a bill that has been kicking around Parliament for a couple of years now, the NHI bill, which will make dramatic and wholesale changes to South Africa's health funding network and system. And we're delighted to be joined today by Mike Settis, who is the Managing Director of Synergy, which is a health insurance provider. And Mike is also very involved in the policy space and is actually a member of the Free Market Foundation's Health Policy Unit. So he's speaking to us today really about the origins of the NHI proposal, what it seeks to achieve, but also some of the risks that are attendant to it. We have seen President Ramaphosa and Health Minister Zweli Mkhize during the lockdown period, during the COVID crisis, saying that COVID-19 accelerates the need for an NHI system. But as we have warned in many of our risk alerts and other reports, we view the NHI as potentially highly risky in terms of the fiscal situation that the country finds itself in, but also potentially crowding out private healthcare providers. I'm going to, without very much delay, hand over to Mike in just a moment, but do stay on the call. We will be having a Q&A session during the end part of the session. So Mike's going to be speaking for about 25 minutes max. There is a Q&A feature in the bottom of your screen on the taskbar there. So if you have any questions that occur to you during Mike's presentation, do post those in the Q&A and we'll get to them during the last part of the discussion. We'll also be having a poll at the end of Mike's presentation. And we do have the opportunity to activate microphones if you prefer to submit your question verbally and engage directly with our speaker. So you'll just have to raise your hand for that, but that'll be at the end. All right, Mike, I'm going to hand over to you. Please do take us through your presentation.
Thank you very much, David, and welcome to all the attendees. Thank you for being here today. So, we've got some interesting things to talk about. Possibly the biggest proposal this country's ever seen, but let's see how it goes. So the case against national health insurance. Just to have a look at what you're going to look at today, so health policy and what the history of that has been, what SA's public health sector looks like, competition in healthcare and why it's essential, and then some of the fundamental flaws that I see in terms of this NHI proposal. So if we have a look at a history of health policy in South Africa going right back to 1995, 25 years back, it started off with an ANC health paper that was drafted by Drs. Olive Shisana and Jonathan Brumberg. 2 years later was the establishment of the Taylor Commission, which was tasked with looking into a social security structure for South Africa, mainly focusing around retirement reforms and healthcare. In 1998, the Medical Schemes Act was promulgated. And a few years later, the Taylor report eventually came out of the Taylor Commission, and the health component of that spoke about establishing a social health insurance, which was really going to layer in between the current public health system and the medical scheme markets to provide a funding mechanism via a payroll tax for everyone who was employed, but not on a medical scheme. In 2004, after pressure from the medical schemes markets, a policy initiative was established called the Low Income Medical Schemes, or otherwise dubbed as LIMS. And that was really recognizing that the current prescribed minimum benefits in the medical scheme world made medical schemes too expensive, and really, for the vast majority of employed people, were not able to afford it. So that was the initiative came about. It lasted for about 2 years of various committees. Unfortunately, it was cancelled again in 2006. It was off the table. If we then look further, 2007, and as you would recall, there was a major political change in the change in the ruling party leadership. And subsequently, what happened, the Taylor social health insurance policy was abandoned, most notably because of the payroll tax that was pretty much hated by Labour. And then NHR was born a year later on the premise that NHR was free. And that obviously favoured very much the left in terms of their thinking. By 2011, there was an NHR Green Paper. In 2015, we see that low-income medical scheme initiative started again and ended in the same year. And in December of 2015, the NHR white paper was produced. 2017, for a third time, LIM starts again. And then 2019, there was quite a bit of change last year. So NHR bill was finally passed by Cabinet. The health market inquiry, which is an inquiry established by the Competition Commission into the functioning in the private healthcare sector. And was really looking at the effectiveness of the private sector. It took about 6 years, very well structured, wide stakeholder engagement, evidence-led inquiry, and we'll talk a little bit more about that just now. And then LIMS ends for a third time, so a little bit like Groundhog Day, just going on and on. But I think the point I'm trying to make here is, in the space of 25 years, we had a lot of proposals, a lot of commissions, a lot of papers. The only piece of legislation that's been passed in terms of healthcare in the last 25 years has been the revision of the Medical Schemes Act in 1998. A lot of up and down and back and forth. If we go to that health market inquiry findings, just some of the key issues of their views on how the Department of Health regulated the private sector. And their view was that there was inadequate stewardship of the private sector. The failures, they believed, that they didn't use the existing powers to manage it properly, not holding regular reviews, and not holding regulators accountable. And as such, their view was that as a consequence of these, the private sector is neither efficient nor competitive. So these are fairly compelling views that came out of the Competition Commission. What it really meant was that South Africa was denied an affordable and more expansive private sector. In terms of looking at one of the principles in the National Development Plan, the key principle that should be applied across all governments is the separation of political interference from public service. When we have a look at this NHR proposal, we see it as quite the opposite. It wants to really conflate it far, far more than it should. There's a very high concentration of House and Minister of Health in the bill. Basically, control of all the appointments of all the executives, plus all the committees. I think there are about 9 committees inside the NHR bill, from accreditation to reimbursement rates, etc., etc. And there's a little oversight of that, which I think is a real problem. And we have to remember what the NHR is talking about, a legislated national monopoly of the funding and delivery of all healthcare in South Africa, or certainly the vast swath of it. So let's have a look at the basis of this proposal. Essentially, at this point in time, the private sector makes up about 4.4% of the GDP, and that's the vast majority of those is funded by medical schemes. The public sector makes up about 4.1% of the GDP, and that's the public health sector there. And the proposal, in a nutshell, is to say we take the money in these two sectors and put it into the NHR fund, into a single payer model for the whole country. And we'll then have 8.5% of GDP in which to fund all the healthcare in South Africa for all citizens. The public sector funding is 100% tax funded, as we know. Private sector is 100% privately funded. So obviously, in terms of how things are structured now, government can't really access the private sector money in the current legal structure. So the only way in which to do that is to legislate an NHR monopoly by creating a single payer NHR fund and then banning medical schemes from competing with the NHR. So if we look at our single payer NHR fund with needing 8.5% of GDP, the public sector proportion of that can be pushed up to 5.5% by taking the existing Department of Health's budget, which is sitting at 226 billion, removal of the medical tax credits for medical scheme members, that gives another 25 billion, and then removal of the state subsidy to to their employees for membership of a medical scheme, mainly via the GEMS medical scheme. And that's another 35 billion. So that was about 286 billion per annum, which means that short of 3%, which needs to come from the private sector. The only way in which it can really be done is through so that's 164 billion in the very rough terms if we put it into the green paper, white paper, and the bill. And that is an entity in 2018 values of 450 billion rand per annum, almost 3 times the size of Eskom, another state monopoly, and we think we kind of all know what the picture is there. So I thought Dr. Jack's demonstration of what he felt about the NHI might be quite apt, but anyway, for all the humor for today. Okay, so the SAS public health sector, let's have a look at that. So to give context of how South Africa spends on healthcare, I took on a per capita GDP basis, I took South Africa, and then I took all the countries with a higher per capita GDP above it, up to a maximum 200% of our GDP. And that gave a cohort of 31 countries, including South Africa. So we're the poorest country in this cohort. But if we have a look at those exact same countries and how they spend on healthcare, and I'm talking public healthcare very specifically, note that South Africa moves from last position up into the third quartile. So in comparison to our peers, our per capita spend on public health is not bad. It's higher than average. It's certainly higher than our wealthier peers. But if we have a look at what the problem statements that come and why, contextually, why this NHI proposal is on the table, these are the types of things we've been hearing for forever. This is just a quote from a parliamentary session last year in which Dr. Mkhize said there's a shortage in the public sector. Health budget hasn't increased in real terms, and that's why the number of staff can't be appointed in the public sector. But let's examine that, because the numbers tell us a totally different story. Now, the source of this National Treasury, amongst others, there. So this comes from within government itself. In March 2006, 140,000. March 2012, March 2016, almost 200,000 public sector medical personnel employed within the sector. That's a 42% increase in personnel. So I'm not sure where Dr. Mkhize gets his numbers from, but that's fact straight out of Treasury. So we've got a lot more doctors than we had in the decade before. If we have a look at public sector outcomes, a measure of infant and maternal mortality rate gives us a good measure of the effectiveness of the health system. And if we look at a comparison between our peers in upper middle income countries, this is how South Africa fares in terms of those. In terms of infant mortality, our rate is 2.5 times the average of those upper middle income countries, and nearly 3.5 times higher for maternal mortality. It's not a good sign that we're actually delivering good quality healthcare. First to that, if we look at this office, Health Standards Compliance, which is a department within the office within the Department of Health, and we can kind of create this or define this office as a clinical auditor general. So they would do audits of public facilities on a clinical measure basis, and it's a whole range of different metrics that they use. And their current function is to provide a quality measure of what's happening in public facilities. In the NHI world, this office is going to be defining the quality, and then subsequently, based on that measure, accreditation for public facilities and private facilities to be able to contract with the NHI fund, so that they will need to meet a certain minimum level before they'll be able to contract. If they can't contract, they're out of the picture, and that would apply to both public and private. So the last audit report that the Office of Health Standards put out was in 2018, and they inspected 696 public facilities, ranging from primary clinics right through to full-scale hospitals. We have a look at the results of that there. So the scorecard on the right shows that's a score. It's categorized into those six categories there. And for a facility to be able to contract with the NHI, they are going to need to achieve a minimum score of 80%. So a good standard and what it should be. But let's have a look at how many of those 696 facilities reached that 80% score. So as you can see there, top 1%. So seven out of 696 facilities actually reach that score. And if we look at the rest of the scoring, it really doesn't paint a very pretty picture. We have a serious problem in terms of quality adherence, in terms of management. I mean, much of this has been outlined in the public in the past, but I mean, this really sort of contextualizes it, coming out of a very formal audit process, going into a lot of depth and detail. So we have serious problems in terms of trying to get public health up to a level of standard that is acceptable. And obviously, if you are looking at this picture here, then you have another problem that arises, and that is medical malpractice liability that sits within the state. And this is substantial. So take a look at that. Just look at the magnitude in 4 years. That's almost quadrupled. I understand that it's now in excess of 100 billion. If we contextualize that against the national full budgets, saw that number earlier, 226 billion. That's 43%. So this carries on this trend. In a few years' time, it's going to be 200 billion. If we throw this in with the likes of the Eskom debt problem, countries facing some serious liabilities. And again, nothing is ever said about this. The NHR proposals outline what they outline, but there's nothing about, is this going to go away? Not touched on at all. I'm going to move on to competition in healthcare and why it's important. I think it has to be contextualized what government's rationale for NHR is, or one of the core rationales. So this single payer monopoly NHR fund with nationally centralized procurement will reduce costs and improve efficiency. So that's the context of which it's proposing the NHR. So I'm suggesting let's test that rationale against somewhere else in the world. The British NHS is often used as a benchmark for national health systems. I mean, it's world famous, always attracted a lot of attention. From its inception in 1948 through to 1990, plus minus, it was a centralized monopoly, and it operated pretty much on the basis of which the current NHR proposals are proposing. But during the 80s, the British realized that the system wasn't working very well. It was riddled with inefficiencies, bureaucratic layers that just didn't work very well. And they went through a process of decentralizing it. And they have successfully done that over the last 30 years. So the NHS today, although on the outside it looks like it's the same, it doesn't operate nearly the same as what it used to prior to 1990. In essence, what they did is they created competition within the system. Patients were allowed to choose their own doctors, their own facilities, so that money followed the patients, and there was competition amongst the providers to compete, and there was substantial quality measurement within outcomes in the NHS, which has helped enormously. So the results of all of this were improved outcomes, reduced waiting times, and cost, in real terms, cost decline. Now the NHS still lags behind its peers, counterparts, but it just emphasizes this point that the centralized approach doesn't work. The decentralized approach is much more successful, and hopefully they'll get up to being next to their peers at some stage in the near future. World famous Professor Michael Porter from Harvard, who's spent most of his life working in terms of healthcare systems and how they best operate, and he's adamant about it that monopolies rarely, if ever, are able to provide the type of care that a system that's based on competitive markets would behave. Closer to home, we can look at comments from Professor van den Heever from WITS. My own emphasis here on some of these points. I mean, as he says, they're proposing to centralize what should be decentralized. And the purchasing function should not be at a national level, it should be at the regional level. And that type of structure is well known in many health systems around the world. As soon as you create a nationalized bureaucratic structure, it becomes incredibly inefficient. And also, I think the professor was being kind in terms of using the word inefficiencies, because that sort of goes more to the point of like massive grand scale corruption. It's really what you do when you get to these sort of structures. Look at some international experience. The single payer model, which the NHR fund is the way it's being proposed, is exactly that. But there are two variants to a single payer model. The first is a complementary system, which is what the NHR proposal is. It creates a public monopoly, and the private sector is marginalized from it. It cannot operate, it cannot compete with the public system. The other variant is a supplementary single payer model, and there that allows private sector to compete with the public sector. So it's an opt-out for citizens. They don't have to use the national system, they can opt out. And South Africa currently mimics the supplementary single payer model. Although we don't have a single payer, we do have university tax funded care, which is the public system, and then through medical schemes and health insurance, members can opt out. So in essence, it's a supplementary system. But let's have a look at the complementary examples that exist in the world. There are precisely 5 of them. Canada, UK, Taiwan, Estonia, and Cuba. So only 2.5% of the countries in the world have decided to build a complementary single payer model. And there's simply a good reason for it, is that all healthcare has to be funded through the tax, through the fiscus, which in most cases is simply not possible, and certainly in our case, it's exactly that point. Cuba is the only developing economy in the world with a complementary system, but they have a health system in which they basically sell their doctors to the rest of the world. So it's a big import for them, and that's the only way that they can realistically sustain that. Everywhere else, any other developing economy, it just simply is not an option. If you look at the country like it's also a developing economy, they have private funders, private providers. The public funder, which is it's just a single payer system as well, and they have public providers. But everyone purchases from everyone. Private funders and public providers, public funders, private providers, etc., etc. So it's, all the assets of the country are locked together, not on a voluntary basis, so that all those assets can be leveraged in a sustainable way. If we have a look at countries like Germany, they have nationally mandated coverage, but there's no single fund. They have a choice of 130 sickness funds to be equivalent roughly of what we have as a medical scheme. Australia has nationally tax-funded health system, but still nearly half of all citizens have private cover. Ireland, they had a proposed universal health insurance scheme some years ago, but they abandoned it in 2015 after they did a comprehensive costing analysis, and they found it to be unaffordable. To date, the NHI has had no costing analysis done on it, so we're afraid we're going down this road, but we still simply have no idea of what it's going to cost. And I think the emphasis here is these are all first world countries, and they're arguing that they're unable to sustain these types of structures. I'd like to look at some developing economies here. So let's take Mexico, Thailand, Brazil, and Korea. The figures in the blue block at the bottom are the weighted averages of these countries. And there we see in this red circle the tax base of nearly 30% and an unemployment rate of 3.8 in these 4 countries. By contrast, we now have these figures. These are pre-lockdown, so these we know are obviously going to get worse in the near future. So the position is even worse than what we're looking at in terms of those figures. And to contextualize what I'm going to talk about now, the NHI is promising comprehensive healthcare that will be free. Okay, so very populist in its messaging. Let's have a look at some of the countries. So Korea, in their national system, they have patient co-payments at the point of sale. The patient has to make a co-payment on inpatient treatment of somewhere between 10 and 20%, on outpatient treatment anywhere between 30 and 50%. So they can't sustain free healthcare. And they have a payroll tax of between 5 and 10% to fund it, and 96% of all employed citizens contribute to that fund. Thailand, their public system is able to cover about 65% of the population, the balance in private. Mexico, the out-of-pocket expense, which is very much like a co-payment, averages 40% in the public health sector. The total private spend in Mexico makes up 52% of the entire combined spend. So these are countries that are developing economies like us, but their metrics are way better than ours. So they cannot provide comprehensive and free healthcare, but we're promising that in the NHI context. So just to some fundamental flaws that I see with this proposal, it's the creation of an absolute state-run monopoly. We've already seen the disastrous problems of other monopolies run by the state. It's asking for the centralization of the procurement and accreditation of the procurement of all services and accreditation of all providers. This is a recipe for substantial corruption, which not going to go down too well. There's no separation of powers within the bill. The Minister of Health has accorded way too much power. We're going to see political appointees, and it's unlikely we will see any public accountability. There's also been no technical analysis in terms of how NHI is going to be, how we're going to transition into the NHI. It's a massive change in terms of both the private and public sector. There's been no technical analysis. There's been no costing on it either, so we don't even know what it's going to cost. Fiscally unrealistic in terms of taking away the right of the private sector to fund themselves. So we're taking everybody now and putting it into the private. People currently on private and relying on public will all go into one pot. So we're actually reducing the amount of money that's available on a per capita basis. Because fiscally, we'll never be able to raise more taxes, certainly not in the next 2 years. And the nationalisation of the private sector. I think we've got a world-class functioning private sector now, to be basically taken over and run by governments. But the message still comes across in a very mystical, magical way. This is a quote from last year in July. Silver bullet on its way. We have a look at the other public-run facilities. I suppose I don't really need to delve too much into this, but I mean, it's not got better. The track record is not great. Eskom, or NHI being the Eskom of healthcare, that is in essence what the NHI does. There's a state-run monopoly. Private sector will be crowded out, and we see the results of what we have with that now. So I cannot imagine that within the NHI as it's structured now, we're going to see anything more different. So just to conclude, in a nutshell, from 2006 to 2016, as we saw earlier, medical personnel in the public sector increased by 42%. So there's more money, more doctors, outcomes have not improved. My opinion is we cannot afford another tax. We certainly cannot afford more wastage of taxpayers' money. The only realistic option is to fix both sectors, the public sector and the private sector. In terms of the public sector, corruption, unfortunately, is enemy number one, like it is in many other departments. This has really crippled the department and what prevents it from being able to function properly. And until that is removed, we're not going to fix anything. NHI is not going to fix that. And NHI doesn't even talk to it. It doesn't even mention it. Procurement policies in the public system are ignored. And there's no outcomes measure, which really is the essence of all health systems. You need an outcomes measure to assess the quality of these systems. The private sector, we had the health market inquiry, it ran for 6 years. It cost taxpayers 200 million to put together, but it was an evidence-led process. It's wide stakeholder engagement. Their recommendations are sitting there, and if we can implement those, we will. I think we were able to fix the cost escalations that are rather prevalent in the private sector. I think there needs to be a revision of prescribed minimum benefits, and we need to look at either introducing mandatory coverage into our existing system to reduce the very high levels of anti-selection that exist within the private sector, or we need to switch the whole system to a more risk-based system. But in its current form, it is simply not sustainable. But just to leave you on a note here with this, Brazil has the world's largest public health system, covers 155 million lives. And right next to it, it has the world's second largest private healthcare market, next only to the US. It's a sense of pragmatism and realism that brings in the Brazilian government actually offers incentives and structures to private sector to come in so that it alleviates the public sector, the more people we have in the private sector. Thank you very much for listening.
Mike, thanks very much. I thought that was a very interesting and concise explanation of some of the risks around NHI. We're going to now open up the floor for questions. But before we do that, we have prepared a user poll. So we're going to just put that poll up very shortly. And let me just activate here. All right, so you should see a notification. It says NHI, good or bad? And we're receiving votes now. The votes are coming in. Are you in favor of NHI? Yes, no, or a third option, you need a greater understanding. So those results are coming in at the moment. We've had 17, 18, and we'll review that as they come in. Looks like the no votes are leading the pack there with 71% of votes, 15. And then those who say they need a greater understanding, that's 24% or 5 votes. And then there's a single vote for yes. Just bear in mind that these results are anonymized. So please feel free to answer frankly there. All right, well, Mike, we've got a couple of questions coming through here. And I should just add before we transition to the Q&A as well, that these slides will be made available, and there's also a recording of this session will be posted on the CRA website that's behind the paywall, so you'll need to log in to access that. All right, well, Mike, we have a question here from Johan. He says that in summary, we can conclude that NHI is a fundraising activity for the government before we reach the end target of a failed state, stealing as much as possible before all the money is gone. Prescribed assets 2.0, he says. Yeah, I mean, I think that's a theme that came out quite strongly in your presentation, Mike, was just the fiscal risks, but also the governance risks that potentially having a highly centralized system will increase the opportunities for theft and malfeasance and corruption, and also the point that you made about political appointments being made a highly concentrated appointment process in terms of how the DOH will assign personnel to administer the fund. Are there any other points that you'd like to add there, just in response to Johan's question or comment?
I think what's relevant is that the government's perpetual scapegoat is that they don't have enough money in the public sector to deliver a better quality of care. But in essence, they do. If we compare South Africa's per capita spend versus the outcomes against many other countries produce better outcomes than we do with lower per capita budget. We just need to spend the money more efficiently. And this NHI proposal talks nothing about that. It's just talking about raising more money. And with the promise that with more money they can deliver. To me, the essence should be first do the best with what you can, and then let's see if we need more funding. To pour money into a corrupt state as we have is just simply reckless, in my opinion.
Yeah, so you can fill the bucket, but if the bucket has holes in the bottom, then that money is yeah. And I think just to underscore that point, the finance minister during a parliamentary question session was recently asked, what is the accumulated bailout funding that has been provided to state-owned enterprises? Over the last 20 years, his report was that 180 billion rand had been provided to SOEs in various capacities, including Eskom, SAA, etc. So that is a substantial quantum of money that could be used to finance other state projects, other activities. So I think there's a real risk there. But nevertheless, Mike, I think that we have some pretty serious problems in South Africa around access to healthcare, which is ultimately what we're trying to promote is a more effective system, a more inclusive system. So Roberto asks a question, says the NHI is obviously not the viable solution for the South African healthcare system. What would be the alternatives to the NHI introduction to fix the situation of the South African healthcare system, especially in the public sector?
Well, I think, one of the ironies about the South African public system is that with the previous governments, with the pre-apartheid or in apartheid, it was built all around the cities to cater for the minority, and that didn't work in those times because the majority of the population lived in the rural areas. Now, as the years have gone by, and like many countries have, the trends are that there's a massive urbanization. So we now have, I think, close to a 65-35 split, urban versus rural. So the public assets, infrastructure is sitting in the areas where the people need the care. There are obviously pockets in rural which still struggle with that. But the structure that we have is in essence not a bad structure. It just needs to be managed better. And that can deliver a far better level of care than what we're seeing at the moment. The loss of funding to various, the medical malpractice, the corruption, it's debilitating to certain facilities. We just see their money disappear into corrupt activities, and then things just don't get purchased. Things can't be purchased. It's a massive problem.
Right. Thanks, John. Sorry, Mike. We have a question from John as well. If universal coverage was the goal, what would be the best way to achieve it? Similar to the previous question.
Yeah, this whole issue of universal health coverage. South Africa actually already has a system that delivers a reasonable level of universal healthcare. The World Health Organization accords us a score point of 0.67, which is slightly higher than the world average of 0.64, one being perfect with 0 being non-existent. Again, it comes back to the issue of the fundamental structures there. It's just the management inside the system that is the problem that prevents us from being able to deliver a more universal level of care. If we compare ourselves to African countries, our universal health coverage is way, way higher. So as I say, we have the infrastructure, we just need to manage it to a greater degree, far better than we have already. We will find substantial efficiencies if we can root out the issues of corruption, the incorrect appointments, et cetera, et cetera. We all know these things.
So now, Mike, just a comment from me. I mean, in terms of the government responsibility for healthcare, that is a shared competency between the provinces and the National Department of Health. So do you think that there is a kind of administrative inefficiency there or ineffectiveness in terms of the duplication of functions, duplication of bureaucracies, and lack of communication between those? Is this, I mean, that is obviously a constitutionally mandated provision, but do you think that that is part of the problem, that there's a disconnect between the provinces and the national?
It's difficult on that. I'm not. I certainly don't think that the centralisation that the NHR is proposing is an answer to that. If there is that disconnect that exists there, I would suggest that if we could get a quality measure system or an outcomes measure system within the healthcare system, like the NHS runs on, which can then be fed into the public domain, which then allows consumers to access care at areas that they are. You'll start seeing a drive towards greater levels of quality and outcome. So I think in terms of all healthcare systems, you want to take away the bureaucratic side of it and rather get providers and institutions to focus on their own outcomes. And once you start getting that psyche into the whole system, that just improves it across the board.
Yeah, and so often with these things, it's about incentives and accountability mechanisms. And, I think management is a bit of an intangible thing sometimes, but can also just be about instituting rules and basic procedures that are followed through. Right. Well, we have a question here from Chris. Could you speak to some of the failures of government in preparing for COVID-19? This was a great opportunity for them, in inverted commas, for them to show that they're capable with the country under lockdown. But they took months to procure beds and ventilators. Surely even the dry run shows they don't have the skills to manage healthcare challenges.
Look, I think the response wasn't great. Obviously it was a very when it's an outlier in terms of what it was. But just for example, the inability to get testing. Initially when the lockdown just started, I think it was the president who said that they would be getting the NHLS up to 36,000 tests a day. They got absolutely nowhere close to that. Whereas the private sector, I think, is currently exceeding 40,000 a day, or was at some stage. I'm not sure if it still is there. But the capacity, the ability to do it is, they're worlds apart. In terms of the I know in the Western Cape that eventually they stopped testing because it was taking 8, 9, 10 days to get the result back. At which point, the idea of testing is to then do contact tracing and quarantining. But you can't go back to someone 8, 9, 10 days later to try and then do contact tracing. So the whole capacity of being able to contain a pandemic like this is that you have to get those 3 simple steps: the testing, contact tracing, quarantining has to be super fast. Otherwise, you're actually wasting your time even doing the tests. It could be done better. So it hasn't been great. And I cannot see how any of the officials could claim that this was a good dry run and they were able to do it. In actual fact, South Africa got it very lightly into it. We have to realize, our death rate and our infection rate is substantially lower than many other countries. If it had been, say, 3, 4, 5 times what it was in this country, so it was more like an Italy, we would have been in very serious trouble.
Yeah, and we've done quite a number of briefings and webinars on that topic. I think do check out the webinar that we did with Panda, Pandemics Data Analysis, for more insight on that. There's a question here from Laurie. What are the glaring fault lines in the private health sector in South Africa?
Yeah, just how much time do we have? But to me, I think the biggest problem, and this is something that I've been harping on about for years now. If you look at costs in the private sector prior to 2000, when the current Medical Schemes Act came into play, although it had the trend of above inflation, which exists in virtually every country in the world, it was moderate. And from 2000 onwards, when the current Act came into play, which created a very unbalanced regulatory framework, you can see in terms of hospital costs, in particular, that I like to track, there's just this ramp up in costs, because the way the system is structured now is you should have mandatory coverage in the medical scheme world, because there's open enrollment and there's community ration. That means somebody can join at any stage, at any age. They cannot be declined, and you cannot even ask them a higher premium. So creates massive anti-selection. Only the sick people join, the older people, unless it's by virtue of the employment, but that doesn't apply to everybody. And that's what caused these massive cost increases. Now we need to either have mandatory coverage in, or we need to say we do away with the social solidarity principles, because we've currently got a half-baked private sector framework. And I think that one thing I was delighted about that came out of the health market inquiry last year was that they emphasized that the private sector is sitting in a half-baked regulatory framework. It needs to be fixed. It cannot be left as it is.
All right. So Paul has a question. Do we have any examples in South Africa of successful public sector institutions in the healthcare sector that the government can use to prove they have the capacity to deliver?
Look, I'm very sure that there are. I'm not so much my involvement is more on the funding side than really on the actual delivery side. But there certainly are pockets of excellence. I think if we talk at a sort of provincial level, the Western Cape certainly does provide a good example of much better run public sector delivery. And that's evidenced in the 100 billion rand number, the medical malpractice liability number that I showed up earlier. Only 2% of that comes out of the Western Cape. If we take the Eastern Cape, more than a quarter of that comes out of the Eastern Cape. So it's a glaring example of how two vastly different run provinces have vastly different risks.
All right, thanks, Mike. So Roberto asks, should the NHI be introduced as presented by the ANC at present? What do you see as important consequences for the global quality of the healthcare provided to the public as well as the South African healthcare providers? So that's doctors, nurses, etc., and why? So what's the quality what is the consequences on quality of healthcare provision and also on healthcare providers as well?
I think we're going to, I think at a provider level, the one problem that's key, and a number of the provider associations, the private provider associations have canvassed their members, and that we're going to see a brain drain. which is really going to exacerbate the problems we already have, because we really don't have sufficient providers in the country. To provide quality care in any system, we cannot bureaucratically control that from some central point. It has to be devolved down to at the level of care. The level of care that's needed in, say, rural KwaZulu-Natal is totally different to what's needed in urban Cape Town. So if you're making those decisions at a bureaucratic level, to me the quality can only go down. It's going to put more pressure on providers, individual people, the doctors, nurses working in the system. So that'd be my major concern around this thing. I mean, besides the issues of corruption and all of that, I mean, that is in of itself, but you don't deliver quality from a bureaucratic command and control style. No, certainly not in healthcare.
Right, Mike. Well, I mean, one of the points that you raised is around the quality control. So now, is there a risk that if private facilities, would they be mandated to serve customers under the NHI framework? And could those facilities become overwhelmed?
Well, I mean, yes, I mean, the principle of what the NHI is saying is that everybody's in public and private. So it's about merging them into not necessarily merging the departments, but everyone has to deliver the care. So if in the basket of care that exists within the NHI, which is yet to be defined, if say dentistry is one of those services, then all dentists in the country will have to deliver care through the NHI. They won't be able to have a private practice where they're contracting with medical schemes, because medical schemes will be prevented from financing and funding those services. So in essence, it brings it all together on that basis. The major concern is, at what price, and if that's going to be dictated to as well. Providers, those private providers feel that it's not sufficient to sustain their practices, then the obvious thing is that they're going to go elsewhere. They'll either leave the healthcare sector or they'll immigrate. And to me, it's very, very difficult. These are issues that haven't been addressed in the NHI for all the proposals. One of the numerous technical issues that haven't been dealt with.
So, Mike, in terms of the organized healthcare associations, particularly of health funders, has there, in terms of the public engagement with government, I mean, how have those public engagements gone? Have they, what we've seen a lot of the time, particularly with organized business, is that they go along to get along and try to maintain good relations with government, but they actually end up reinforcing bad policy in the hope that they could perhaps dilute it or extract concessions. Is that a similar story with this NHI discussion?
Yeah, I tend to see that the big players behind doors are saying, oh, they're quite concerned, but in public, I wouldn't say they're being completely in agreement with the proposals. They are voicing some concerns, but they're certainly not being overly critical about it. There was the NEDLAC committee that was, I think it was established towards the end of last year or early this year, with 6 representatives from private and public, and I thought that might have some legs in terms of addressing some of the concerns, but I doubt much work has been done on that. I presume that the lockdown has kind of postponed that like it's done with many other things. But other than that, there hasn't been stakeholder engagement other than the public roadshows that the NHI performed at the end of last year and early this year. But that's really only engaging the end user. It's not fun to engage, say, the hospitals or the medical schemes or all the other assets in the private sector. And the point about those public roadshows was, if you go to somebody who's sitting in living in a township in poor situation with poor access to healthcare, and you say this NHR is going to bring them healthcare, obviously they're going to agree with it because that's what they want. The mechanism by which it's brought to them is of no concern to them. They only want better healthcare. So that the roadshows didn't endorse NHR, in my opinion. They just endorsed that they want better healthcare. And that can be achieved in numerous ways.
And is it correct to say that the Department of Performance Monitoring and Evaluation, the CS system, the Socioeconomic Impact Assessment System, has that mechanism been applied to the NHI, or did you argue, I think, in one of your earlier slides that has been bypassed?
It wasn't bypassed. I don't think it was done to any great credible extent. It kind of created a binary assessment of either the options that were available was either we privatize the entire country's health assets or we nationalize everything. Whereas virtually all health systems around the world are a good combination of both private and public. So I think I wouldn't want to use the word whitewash, but it wasn't too far off that, I think.
Right. So we have a question here from Johan, who asked an earlier question. And Johan says, what are your thoughts on the idea of a voucher system being implemented with the DOH budget and disbanding the department? After the ANC is voted out, as under the National Democratic Revolution, it would never be implemented. That's a rather caustic remark from Johan, but I think a good question. And, I think it's very important to say, well, what are the alternatives there? If we're going to criticize the system, how could we potentially offer better alternatives?
Well, so look, I mean, a voucher system can work. It's used in Brazil to varying degrees of success. It depends. I think it's like many other things. It depends how it's structured and how it's put together. I mean, the one thing that it does do is it gives freedom of choice to the consumer, the end user, so that if they receive a voucher, they can redeem it with the provider of their choice. And in many, like in Brazil, it could be a private or a public provider, someone of their own choice. And then again, it's a case of the money flows, follows the patient and the provider that they end up choosing. So it's something that I think would need to be investigated to see if it could work. It does take, the voucher system does take away the automatic allocation of budget to a department, regardless of whether the patients are going there or not. So it has that advantage, but there are other issues that need to be considered in it. So yes, it can be looked at, but it doesn't resolve all problems within the publicly funded system.
All right, Mike. Well, I don't see any additional questions in the Q&A, but if there are any final questions, you can raise your hand or post a final question in the Q&A. But I think just Johan, in his earlier question, made a point about this being prescribed assets 2.0. And I think it's been very interesting to observe the prescribed assets debate unfolding over the last couple of weeks. And prescribed assets obviously part of the ANC's election manifesto and their 2017 party Congress resolution from NASREC. And we've had big ideological push for prescribed assets from within the party. But there's also been pushback from various stakeholders, organizations. And what we've seen is a retreat on the issue from Paul Mashatile, the treasurer of the party. So I think that's quite an instructive lesson there, that some level of robust engagement over policies that could have damaging consequences. I think there's definitely a place for that. And I think the president's style is consensus seeking and bringing all stakeholders into the discussion. But sometimes industry players need to take hard lines and say, well, no, we cannot entertain this proposal. Here are much better alternatives that you can consider. And I think that this conversation that we've had today, Mike, is in that spirit. I think we've been critical, but also offering some very good alternatives and some proposals that could make a big difference in many people's lives. and improve their access to healthcare, which is a critical public policy issue in South Africa at the moment. So I just wanted to thank you very much on behalf of the Center for Risk Analysis, and we really appreciate you sharing your technical expertise with us and your perspective. We've done quite a lot of research on NHI ourselves, but I think the granularity with which you've explored the issues has really added a lot to today's discussion. And yeah, thank you very much. We will be circulating these slides and also making the video available on our website. Mike, any last words from you?
Yeah, well, just to say thanks very much to having me on. Thanks to your clients for your attendance and listening. I much appreciate it. Thank you.
Great. Well, thanks, Mike, and look forward to continuing the discussion with you. And we'll be following NHI very closely in our reports and our weekly risk alerts as well. Until next time, that's it from me, David Ansara. Take care and speak to you soon.